Hello and welcome. Today we'll be discussing a potentially vision-threatening condition called Idiopathic Intracranial Hypertension, often abbreviated as IH. We'll delve into what it is, what causes it, how it's diagnosed, and what treatment options are available. Understanding IH is crucial because early detection and management can help prevent permanent vision loss. The idiopathic and idiopathic intracranial hypertension means of unknown cause. In essence, we don't fully understand why some people develop this condition. While we don't know the precise trigger, certain factors are associated with increased risk. These include obesity, particularly in women of childbearing age. Certain medications such as tetracycline antibiotics and high doses of vitamin A have also been linked to IH. However, in many cases, no specific cause can be identified, which is why it's termed idiopathic. Although the exact mechanism isn't fully understood, the core problem in TH is elevated pressure around the brain and spinal cord, specifically an increase in the cerebrospinal fluid pressure. This increased pressure puts pressure on the optic nerves, which transmit visual information from the eyes to the brain. This pressure can lead to swelling of the optic disc, a condition known as papilledema. If left untreated, prolonged pressure on the optic nerve can cause irreversible damage, leading to vision loss. Idiopathic intracranial hypertension predominantly affects women of childbearing age, typically between 20 and 40. Obesity is a significant risk factor, and the incidence of IH is much higher in obese women compared to the general population. While less common, it can also occur in men and children. The prevalence of IH varies depending on the population studied, but it's estimated to affect between 0.5 to 2 people per 100,000 in the general population. This number is significantly higher in obese women. The signs and symptoms of IH can vary, but the most common symptom is headache. These headaches are often described as throbbing, constant, and may worsen with straining or lying down. Visual disturbances are also common, including blurred vision, double vision, brief episodes of vision loss called transient obscurations, and photopsias, which are seeing flashes of light. Other symptoms may include pulsatile tinnitus, which is a rhythmic pulsing sound in the ears, neck stiffness, and less commonly, nausea and vomiting. In some cases, individuals may experience pain behind the eyes, especially with eye movement. Diagnosis of IH requires a thorough neurological and ophthalmological evaluation. An eye exam will look for papilledema. A visual field test is performed to assess peripheral vision and detect any blind spots. Neuroimaging, typically an MRI or CT scan of the brain, is crucial to rule out other causes of increased intracranial pressure, such as tumors or blood clots. The definitive diagnostic test is a lumbar puncture, also known as a spinal tap. This involves inserting a needle into the lower back to measure the cerebrospinal fluid pressure. Elevated cerebrospinal fluid pressure, along with the absence of other underlying causes, confirms the diagnosis of IH. While there aren't distinct types of IH, it can be classified based on the severity of papilloma and the extent of visual field loss. Some individuals may have mild symptoms and minimal papilledema, while others may experience severe papilledema and significant vision impairment. Early identification and treatment are essential, regardless of the initial severity, to prevent disease progression. Treatment for TH focuses on reducing intracranial pressure and preserving vision. Weight loss is often the first-line recommendation for overweight or obese individuals. Medications, such as acetazolamide, a diuretic, help to reduce cerebrospinal fluid production. In more severe cases, or when medications are ineffective, surgical options may be considered. These include optic nerve sheath fenestration, which involves making slits in the sheath surrounding the optic nerve to relieve pressure, and cerebrospinal fluid shunting, which diverts excess fluid from the brain to another part of the body. Frequent monitoring by both an ophthalmologist and neurologist is crucial to assess treatment effectiveness and prevent further vision loss. Since the exact cause of IH is unknown, primary prevention isn't always possible. However, maintaining a healthy weight, particularly for women of childbearing age, can reduce the risk. If you are taking medications that are known to be associated with IH, discuss with your doctor the potential risks and benefits. Early recognition of symptoms and seeking prompt medical attention is key to preventing long-term complications. The prognosis for TH varies. With early diagnosis and appropriate treatment, many individuals can maintain stable vision and manage their symptoms effectively. However, if left untreated, IH can lead to permanent vision loss, including blindness. Recent research focuses on understanding the underlying mechanisms of IH and identifying new therapeutic targets. Researchers are exploring potential genetic factors that may predispose individuals to developing IH, as well as investigating new medications that could more effectively reduce intracranial pressure with fewer side effects. Continued research is crucial to improve our understanding and treatment of this complex condition and to ultimately prevent vision loss in those affected.